So I'm going to talk this afternoon to you about novel disease mechanisms very briefly to bring you into the space for which these diseases are now recognized as being important in terms of the cytokines that are driving the process of inflammation and bone remodeling. I'm going to talk to you about biologics and psoriatic arthritis and ankylosing spondylitis, really exciting areas. And then lastly, discuss the horizons. Where do I think this field is going? And it is changing very rapidly. So we now know that the master cytokines in spondyloarthritis are shown on this slide, and they include the IL-17, actually the Th17 IL-23 pathway, as well as tumor necrosis factor. Now, these pathways share some commonalities, but actually there's more differences between their signaling than there are commonalities. And we know that these cytokines are integral in all of the aspects that we see, including many of the comorbidities. Well, you also know that this slide in terms of T-cell differentiation. I just want to point out to you that it looks like in psoriatic arthritis, the key T cells are in the Th1 and Th17 realm. Now, I should also point out to you that it's not just helper T cells that make IL-17, but also CD8 T cells. And in fact, in a recent paper from Menon's group in the New England Journal, it looks like the CD8-17 T cells are most important in the psoriatic arthritis joint. We also know that Th1 cells make TNF, and so do Th17 cells. So now everyone is grouping together to refocus and think differently about what we should be targeting to treat patients with psoriatic arthritis. And you heard in the really elegant talk by Tony earlier this afternoon how this is playing out in psoriasis as well. Now, we know for a long time now that anti-TNF agents are very effective in psoriatic arthritis. But what's remarkable about these trials, which are designed similarly, as you know, about half the patients were methotrexate inadequate responders, is that for each of these agents which are approved for this disease, the responses ACR 20, 50, 70 are almost identical. And we also know if you look at the skin responses, there are some differences with the monoclonal antibodies appearing to do better than soluble receptors. And these medications have really been key drugs for treating our patients over the last decade or so. But we now am turning to this Th17, IL-17 pathway, and there's multiple areas one could think about targeting, and they're described in this great paper by Miasek, which is dated but still very important and relevant. Obviously, one can focus on the cells themselves, looking at the ROR gamma T pathway, or looking at the STAT3, which is an important signaling molecule that's activated when you activate a Th17 cell. One can use targeted antibodies against IL-17A or AF or combinations. And then another approach, which you know about and we'll hear more about, is targeting the IL-17 receptor, a fascinating receptor for which we now have antibodies that are proven to be effective in both psoriasis and psoriatic arthritis. So, and lastly, an area that I think holds great promise is not only targeting P40, which, as you know, targets both IL-23 and IL-12, but targeting IL-23 by blocking P19. And this is an area that's emerging as being incredibly fascinating, not only for psoriasis, for which it's a home run, but also possibly in spondyloarthritis with some early findings that are very exciting. So you heard this yesterday from Artie, the Secukinumab Summit 1 trial. This is an important study. You know this drug was approved last year for psoriatic arthritis. Just a couple highlights, and that is, first of all, the ACR 20, 50, 70 responses are similar to what we see with the anti-TNF agents. We also saw in this study that there was improvement in both enthesitis and dactylitis. Remember, one of the problems with these outcome measures is we don't know the minimally clinically important difference, so these were statistical differences, but nonetheless I think they're important. We also know that when this was a group of patients who were not exposed to anti-TNF agents. If you look at Summit 2, which is similarly designed, smaller study, 312 psoriatic arthritis patients, about a third or more of these patients were inadequate responders to anti-TNF agents. In fact, this was a very sick group. Many of them had really failed more than 2 or 3 agents. They had much higher joint counts, SED rate, CRP, than the patients who were naive. And the disappointing part of this trial is that patients who have failed anti-TNF agents, much like everything we've seen in rheumatoid arthritis, seem to have a lower response to Secukinumab. So despite the fact that we're using a different disease mechanism, this continues to be a refractory group. And I'll talk about how we might want to think about these patients toward the end. In this group, they didn't see a significant decrease in dactylitis, but the sample size was smaller. Now, the other important question that we really need to struggle with is we know that anti-TNF agents can block radiographic progression. What about blocking the IL-17 pathway? Does that do the same? And the answer here is yes. So we designed this trial from the beginning to combine Summit 1 and Summit 2 of the radiographs in both studies. So the data you're seeing here was preordained to look at both studies together. And I already showed you this yesterday, so I won't prolong the message, and that is you do see, I think the center area is the best for showing the difference. Almost 1 unit progression in the Sharp score in the placebo group that was significantly reduced in patients who were on either 45 milligrams or 90 milligrams of Secukinumab. And you can see also from the probability plot that there's a difference between the two groups. So the good news is that this drug can inhibit radiographic progression, so it is an alternative one can use to anti-TNF agents for patients who either fail them or cannot take these medications. So the other good news is that we have alternatives coming up for ankylosing spondylitis. And again, as mentioned by Artie yesterday, this is a major unmet need for us because patients who cannot take anti-TNF agents or fail these drugs, we really were left with no options. And as you know, DMARDs are not effective for axial disease. So this is a small study, 20 patients, that was presented at EULAR and then also the ACR. And look at this. I mean, these responses are impressive. Despite the fact it's open label in 20 patients, 75% of patients achieved the ASAS-20 outcome measure. Very impressive. And recall that drugs like antibodies to interleukin-6 receptor, using a similar number of patients, really saw no effect, as well as Rituxan. So this is exciting. Another piece of data from this study, which is not shown here, sorry about that, I thought it was there, was they looked at MRIs in these patients, and they found that those patients that responded, so those patients that achieved the ASAS-20, had significant improvement in their MRI signals, which was osteitis mainly, whereas those patients who did not respond, you did not see a change in the MRI. So I believe that this will go to a phase 3 study, and I think, again, this is going to be an important addition for the treatment of this disease. So the other important really addition to ankylosing spondylitis, again, was touched on by Artie yesterday. This, I'm showing you the Measure 2 study. This is Secukinumab. You heard about it from Tony in psoriasis. And this study is a fairly large study, and they looked at the ASAS-20 as well. And you can see here in this particular study that 60% of patients achieved the ASAS-20. Now, this is a sub-Q dosing regimen. Measure 1, which I'm not showing you, was IV for the first 4 doses, and then sub-Q, and the results were really very similar. So this is showing that this drug is effective for the treatment of ankylosing spondylitis, and the side effect profile was actually quite reassuring. And I think this is going to be an important drug as well for treating patients with AS. So here's the MRI signals for the Secukinumab I mentioned before in AS, and this is the 20 patients. I'm sorry I got out of sync. Just showing you again that there was a significant decrease in the osteitis score in the sacroiliac joints in the treated patients who responded compared to those patients who did not. So one of the really fascinating elements that's coming up in the Th17 story is there's a couple of things. One is it's salt. High salt environments can induce Th17, IL-17 expression and Th17 differentiation. And the second is this study which was presented at the EULAR meeting by Rob Inman's group. And what he did was, first of all, to look in patients with ankylosing spondylitis, male and female, and determine what percentage of Th17 expressing cells they had. And he found 2 things that I think really stand out and are shown in this slide, rather complicated, but I'll get down to the message. One is that there were a much higher percentage of Th17 cells in patients with males with AS than females. And secondly, he went on and did transcriptome analysis on these patients. And what you see in the green are the transcriptome in the males, and what's below is the transcriptome in the females. What really jumps out at you is there's a lot more overly expressed genes that we see in the males and the females, despite they have the same disease. And moreover, the genes that are expressed or overexpressed by the males and females are extremely different. So whether or not this is going to hold up with confirmatory studies, I don't know, but I think it's very fascinating. And there is this gender difference in some other diseases that have Th17 cells as part of the pathogenesis. So the other agent that's being looked at in psoriasis and psoriatic arthritis is brodalumab. This is an IL-17 receptor antibody. It really is extremely effective in psoriasis, as mentioned previously. An important paper from Kim Papp's group in the New England Journal. And then this paper was published in the New England Journal over the summer, and this is a phase 2b trial of patients with PsA. And what you note is that the ACR20, which was recorded at week 12, probably a little early for arthritis, we learned from the study, was not all that impressive. About 42% of patients achieved the ACR20. When you move into the open label, the blue section there on the left, you see actually there's improvement, and there were actually no dropouts, but you never know what to make with open label data. But because of these results, we're doing a phase 3 trial now, and the primary endpoint is going to be at 16 weeks. The skin clears up very quickly. It looks like the joints might take a little longer. This was a relatively safe agent in this small trial, but obviously we'll have to see how things pan out in the larger PsA trial and the safety signals that have been coming up in the many psoriasis studies that have been performed. So again, another agent that's showing to be effective and hitting a different component of the IL-17 pathway, meaning the IL-17 receptor. This is Future 2, also discussed by Artie yesterday. So this is Secukinumab in psoriatic arthritis, large study, well-designed, important endpoints, and the bottom line is very similar responses to what we've seen with Secukinumab and also with the anti-TNF agents. So about 54% of patients achieving the ACR20 outcome, and you can see the 50 and 70, also similar to what we've seen, very impressive. And also important, as Eddie already mentioned, improvement in dactylitis, enthesitis, and again, the skin results are very impressive and good safety signals. So it looks like this is going to be an agent that's going to be used in both psoriasis and psoriatic arthritis. Unfortunately, you heard a great talk on Crohn's disease. It looks like blocking IL-17 in Crohn's is not a good tack to take because it actually can make the disease worse. So important, again, to emphasize, as mentioned by many, including me earlier, is that those patients who had been priorly exposed to anti-TNF agents, and that's showing here for both Future 1 and 2. Again, Future 1 is an IV loading dose and then sub-Q every month, and this Future 2 is what I just showed you, is all sub-Q. And basically, if you've been exposed to an anti-TNF agent, your responses go down, similar to what we saw with Secukinumab, and very disappointing, and shows us that one agent in psoriatic arthritis, my belief, is probably not going to be enough for many patients. So we do see divergent tissue responses with IL-17 inhibition. So I'm showing you, as Tony has shown you, data from the skin data on the upper left-hand corner from the brodalumab study, and boy, these results are so impressive. And then if you cast your eyes down to the right, not so impressive for the arthritis. So we see this dichotomy in skin and joints, and we're still trying to understand, what is the bedside telling us about the disease mechanisms that are happening in the joint that appear not to be so present in the skin. And so hopefully by working in a translational approach, we can get some answers to this important question. So what do we know about in vitro data and in vivo models in terms of the IL-23-TH17 pathway? Well, first of all, we know that antagonism of IL-23-TH17 is not effective in RA. So we now have a divergent disease models, which we really never had before. When I started in the field of psoriatic arthritis in the early 90s, it was like we borrow from RA. The disease mechanisms are the same. And then what was really interesting was that TNF antagonists worked in both diseases, so we were lulled into that belief. But it's now clear that these diseases, including SpA in general, are very different from RA. The other prediction was in a lot of animal models and human studies of tissues of psoriasis, IL-22 is a key cytokine that drives a proliferation of keratinocytes. And yet a trial of IL-22 monoclonal antibody in psoriasis really was a failure. So surprising. And we also, as I mentioned before, know that IL-17 monoclonal antibody worsened Crohn's colitis. And one other area, which is coming from Ellen Gravelisi's lab, she presented recently at the ACR meeting, is they have an IL-17 knockout mouse, and they also have worked with cell cultures, and they have shown that the lack of IL-17 may be associated with periosteal new bone formation. Obviously, this is a potential problem in that patients with PsA make new bone without being treated at all. Whether this is going to be translated into this disease remains to be seen, and we'll all be looking very carefully for that potential side effect. So another agent that has been talked about is IL-6 in spondyloarthritis. And you know that IL-6 was shown, antibody was not effective in ankylosing spondylitis. And this trial just goes on to a small trial, phase 2, looking at Secukinumab, which is an IL-6 monoclonal antibody, not against the receptor, but against the antibody itself. And what you note here on the left is that there's no dose response, so that the higher dose was associated with a lower response. And you can see there was absolutely no response in the skin, PASI 75 in the lower right. And also you can see the response in the DAS28-CRP is less than impressive. Because of this, the company decided not to move forward in any more studies of this drug and the treatment of psoriatic arthritis. So what have we learned? We've learned that the IL-23 Th17 pathway is a great target for SpA. We know that IL-6 is not. And we know that the IL-23 Th17 is not a good target in rheumatoid arthritis either. So I already showed you this yesterday. We've been struggling, and it's really a tough disease to treat, and as you know, in your practice, and because you have to consider all these domains. And we've done studies that show that if you get 4 out of the 5 well controlled and 1 isn't, your patients aren't very happy about things. So we've really worked very hard and continue to work with dermatologists and general internists to address these important domains as well as comorbidities, which I'll mention in a moment. And we are now in the process of really finalizing our treatment recommendations, the revision, and that should be coming out fairly soon, probably in A&R. So the other point I want to stress, since I know there's dermatologists in the audience, and we all work with dermatologists, in this really fascinating and important paper, Ken Gordon and Eric Ruderman talked about the 4 quadrants of psoriasis and psoriatic arthritis. And all of these quadrants require a close collaboration with dermatologists. And we also know that the psoriatic arthritis usually develops in the dermatology offices. So we need to be, unlike Tony, many dermatologists aren't as scrupulous at looking for joint involvement. And so dermatologists are busy. They see a lot of patients. So we're working with ways to help them make these diagnoses. And we're taking a lot of different approaches through the GRAPPA mechanism. That includes questionnaires that are given to patients in the office. They can be scored by a clin-tech or a nurse. And if the score exceeds a certain threshold, actually, this was developed by Dr. Husney and her colleagues, one of these, the PACE questionnaire, so that we can actually bypass the busy dermatologist and get the score, and then maybe they can go on and make the call to the rheumatologist. Obviously, we need to be receptive to those referrals, and as Elena showed us, many times they may actually not have psoriatic arthritis. They may have gout or OA, but they still need to be diagnosed and treated as well. So the comorbidities of psoriasis, again, is a very important area that we're now just learning more about. And many of these, by the way, are actually involved with a IL-23 Th17 mechanism. But the average BMI in our large registry of psoriatic arthritis and psoriasis patients between Canada and the United States, over 8,000 patients, is over 30. So this, as you know, obesity is a major problem, as well as the metabolic syndrome and increased risk for cardiovascular disease. So these are all important, particularly in the case of methotrexate in patients who have type 2 diabetes or obesity, where it's been shown by the dermatologist over serial studies of biopsies of liver that this is a major risk factor, both of these, for progressive fibrosis. So I'm thinking about a revised treatment strategy with what we've learned. Obviously, it's important in the office to be able to diagnose the domains that are involved. It's also very important to use some of the tools we now have at our disposal. And I think for us, the biggest advance has been the use of musculoskeletal ultrasound. These machines have really developed in terms of their ability to see blood vessel signals, and they're really quite amazing. We have this Logic E9, which is incredible in what you can see in the joints and also the power Doppler. Acute phase reactants aren't all that helpful. Only 40% of patients have elevated acute phase reactants. And we are all working very hard, as mentioned by Lenny earlier, on cellular and serum biomarkers, which I think within the next 5 years, we're going to have some important markers to, number 1, identify patients with psoriasis at risk for arthritis. Number 2, to predict which agents patients might respond to, TNF or anti-IL-17. And 3, a surrogate marker in the serum of radiographic progression. These are all areas we're working very hard on, and I think because the biology has really gotten much better, as have the tools we can use, like Cytokine machines that allow us to look at antibodies on cells of 30 or 40 different cell types, that we're actually getting much closer. And then the big branch point is whether patients have erosions or not. I've described to you 3 compounds that actually can decrease progression radiographically. And then also, obviously, monitoring treatment with these biomarkers and clinical exam and imaging studies. And most importantly, we've got to bring in this comorbidity piece. And the problem for many of our patients is that they're younger, they see a dermatologist and they see a rheumatologist, they often don't see a primary care doctor. So it's often incumbent on us to be able to address these comorbidities and try and treat them. And I think the other major areas I'll get to at the end is the idea that we have some non-pharmacologic approaches we can take to improve this disease as well. So this is work that we published in PLOS One in October. It looks complicated. I'll boil it down to you very simply. What we wanted to do was to find out if you take patients and you treat them with an anti-TNF agent, in this case it was infliximab, whether or not the patients that respond to infliximab show changes in genes pathways that are similar in the different diseases. So what you see on this particular slide are transcriptome analysis from RA, PsA, and psoriasis patients. There's 10 patients in each group. These patients were basically, we had baseline transcriptome analysis on CD14 positive cells, which are monocytes, and CD14 negative, which are basically T cells and B cells. And what you're seeing are pathways. I know you can't read them, it's not important. These are different pathways that are important in inflammation and actually cancer. And what you're seeing here is the change in these pathways after treatment with infliximab in all of these 30 patients that responded. And what's most notable is you're seeing the pathways that are affected in both the CD14 negative, which is the B cells and T cells, and in the monocytes, are completely different in the different diseases. So each of the pathways in rheumatoid arthritis, psoriasis, psoriatic arthritis, the last one here is actually skin biopsies, are completely different, despite the fact that they were all responders to the same drug. What this drills home, once again, is that disease mechanisms in these particular disorders are very divergent, despite the fact that they have some similar phenotypes. So the other important point that's emerged over the last 3 years is that the treatments for RA and psoriatic arthritis are now starting to separate. And they're separating by disease mechanism. And we know, for example, that a premolacid drug that works in PS and PsA does not work in RA. I've talked about the anti-IL-17. Abatacept is very effective in RA, not so effective in psoriatic arthritis, not effective at all in the skin of psoriasis. So as these new treatments come out, we're starting to understand more about disease mechanisms and those agents that work, and not all one drug works for RA and PsA like we thought initially. So this just in conclusion shows you the development in psoriatic arthritis, which has been really breathless. So between 1973, when PsA was first described by Mullen Wright, and 2003, these were the drugs that were used to treat psoriatic arthritis. The TNFs really ruled for 9 years, and then Secukinumab came out in 2013, apremilast in 14, Secukinumab for psoriasis probably will be out for PsA in the not-too-distant future. And look at all these other compounds that are really in the wings. My own view, as I'll show in a moment again, is I think it's going to take a combination approach to treat psoriatic arthritis, maybe not psoriasis. Maybe one drug will be enough. So what are the horizons? We know now that there's a paper coming out from Laura Coates, who was covered by Artie yesterday, that combination DMARD therapy may be an effective strategy in PsA. That paper will be coming out in the Lancet shortly. My concern about the using multiple DMARDs is toxicity and adherence. We'll have to see how that plays out. We also know that there's striking data, as I mentioned, of this particular agent in psoriasis, and there's murmurings that I'm hearing from my colleagues in Europe that it may be very effective in early studies of spondyloarthritis. Moreover, we know that mechanistic and actionable biomarkers of arthritis risk, treatment and response are coming. I'm not sure exactly when, but I really believe within the next 5 to 10 years we'll see them. The improved imaging of power Doppler is transforming our field, as you know, and certainly the millennials are coming out in rheumatology. This is part of what they're going to be doing in practice on a regular basis and are doing so now. I personally think that in combination therapies, either bitypical antibodies or multiple targeted treatments, are going to be the way to really get at this resistant psoriatic arthritis population. We're all concerned about toxicity. The sepsis that was seen in patients that got anti-TNF and IL-1 antagonists in RA still rings loud in our ears, but we've got to not just abandon that approach. We have to think about it carefully and try and mix efficacy and safety to achieve and improve our responses. And then lastly, a greater emphasis on non-pharmacologic treatments. There is now compelling evidence from the United States, from Egypt, from Italy, that weight loss is associated with improvement in psoriasis and psoriatic arthritis, sometimes dramatic improvement. Now, whether this is microbiomal, whether this has got to do with the fact, as mentioned yesterday, that fat cells have a lot of inflammatory cells, I don't know, but clearly this is a major message we're giving our patients. I mean, if you're prescribing a patient Secukinumab, for example, who's over 90 kilograms, that's costing about $50,000, $60,000 a year. I think it's incumbent on us to tell those patients, you really need to work to lose weight, not only for your arthritis, but also for these other comorbidities which are so devastating. So this is really an important message we're trying to get across in our clinic. I know that Elaine is doing the same thing, and Tony here at the Cleveland Clinic, and I hope you are too. So I want to conclude with that and thank you for your attention.